Welcome, everyone, to the Infection Prevention and Transition of Care series, talking with teens about fistulas with our esteemed guest, Dr. Jillian Warejko-Rossi. Dr. Warejko-Rossi is an assistant professor of medicine at Yale New Haven Hospital in the Division of Pediatric Nephrology. She's also the associate program director of the Pediatric Nephrology Fellowship, as well as the director of transplant at Yale New Haven Hospital. Today, she will be discussing a teen-focused episode on, tackling issues with AV fistula amongst, teens with regards to body image, autonomy, needle phobia, and sharing some practical strategies to overcome them. So thank you, Dr. Warejko-Rossi, for taking time.
Well, thank you so much for having me, Dr. Chopra. This is obviously an area that's very near and dear to my heart through my work with our pediatric kidney transplant patients. And I'm also, in our group, we all see our dialysis patients. So we follow them from the time they're diagnosed to the time they're transplanted and beyond. So this is a conversation that I've had a few times in my career.
That's amazing. And, adults, if you ask them about AV access, they will be like, which access lasts longest? But with teens, they probably will ask you questions like, will people stare? And I think both approaches are rational. So have you encountered such situations, and how do you start a conversation with a teenager?
Yeah, I think when we talk about access, something about it is just so fundamental to the way that we approach end-stage disease in children versus adults, right? So in children, because we know that the wait times are shorter on the transplant list, sort of the way in which we proceed with working them up, there's a certain level of sort of urgency that we feel trying to get them to transplant, because we know in both cases, adults and children, the goal is transplant, right? But we know in our adult populations, they're going to be waiting longer if they're waiting on the deceased donor list, right? And so the access duration becomes a much bigger part of that conversation. And so for when I'm talking to my patients as their kidney function is declining, or if this is a first time meeting them, we're talking about access. And a lot of times there's a component of this that is, how do we do this now so as to limit your time in the hospital, need for reintervention, things like that. And then at the same time, we're also having that transplant conversation at the same time. And so a lot of times I think that's where, if you look at the pediatric data, we tend to lean towards catheters, because the hope is that we've already started that transplant workup before we've even started the dialysis conversation. I think the first thing that I always sort of think about when I'm talking with my patients is like, how do we keep your life as sort of normal, air quotes, as it can be, right? So, I'm a big proponent of home therapies to start. So obviously, like, my biggest workaround for all this is have you thought about peritoneal dialysis, right? Like, that's a total cheat, right? But it's a cheat code that actually has served me well, right? Because we know that the kids are able to better attend school if they're not having to come to a center to do hemodialysis 3 times a week. So, but, that's not always an option, right? So, or, maybe depending on, how the family looks or how the living situation is for that particular adolescent, it's not a great choice for them, right? And so I sort of, as I am sort of laying things out, I'm sort of presenting them all the different options, right? And I do cover like some fistulas and things like that. I think the first barrier we always hit is, the convenience of catheters is you come into the hospital, you have it placed, and then you can go home, sort of perioperatively, kind of thing, depending on the patient. With the fistula, once you sort of like say like, well, you might need other subsequent interventions and, just the invasiveness of the procedure itself, I think that was always the first thing that sort of takes them a step back, right? Like, you've already told me I have to have a kidney transplant, right? Which is a surgery, a scar. And now you're telling me I could potentially have another thing. So that's usually the starting point, is like, how long are we going to need this for? And getting them over that first sort of hurdle of like, it's another intervention. It's more invasive in a lot of ways than, say, putting a catheter in.
Have you had questions about body image concerns,
Yeah,
prioritizing that over medical
yeah,
benefits, and
yeah.
how do you normalize that conversation?
I think I think that's the hardest part about this whole conversation, right? So, like, the benefit of being a pediatrician that you will always have over my adult colleagues is that every single person who's landed in medical school has already done adolescence, right? So, like, we've all had those thoughts, right? Like, we've all been through that sort of phase of life. And so it's very reasonable for them to be bringing those things up. And then I think that you're not going to be able to normalize it in that this is not normal for kids, right? Like, and I think acknowledging that, like, this is a really abnormal situation that we find ourselves in. At the same time, your outcome isn't necessarily the same as, say, adult patients that you're seeing in the dialysis chair next to you, right? So, like, I dialyze children in a center that also dialyzes adults. And so they see the sort of spectrum of adult disease, which I think is hard because it's very different than pediatrics, right? And I think for kids, you have to kind of say, well, let's take a step back because, again, you're not in that phase of life. And so we have to think about what do we do to keep you healthy and safe. And one of the things that I'm worried about is if you're on dialysis for more than 6 months, your risk of infection goes up every day you have a piece of plastic that's in your body, right? Like a catheter. And that can lead to more hospitalizations and things like that. And so sometimes that'll help us start to sort of get to the point of, like, approaching the vascular surgery appointment, right? Which is always step one in all of this. So
I like that idea that, we hear you, we understand your
yeah,
concern of how it looks, but
yeah,
also want to keep you safe
right,
as a
right,
starting point.
right. And sort of playing to those other things, like, again, because pediatric disease can oftentimes, the reasons kids go to end stage renal disease it's different than on the adult side of things. Some of these kids have already had exposure to things like steroids and other medications. So their body appearance may have already been altered, right? So they're already a little bit primed for that thing that has changed the way they look, right? And so if you come to them and say, like, I'd like to do one other thing that changes the way you look at your body, they're just going to kind of shut that down. They're very savvy. Like, and so, like, when I'm kind of approaching this, I say, look, I get that it's something you can see on the outside. I get that. But while that may be something that's visible, right? The catheter is also still visible in some way, shape, or form, right? If you have to have another procedure for the catheter, well, I can't guarantee it's going to end up in the same spot. So now you've had 2 spots potentially on your body that we've had to intervene on. And then I start to sort of play up some of the, or not play up, but, like, sort of talk about, like, some of the other benefits, right? Like, if you have a fistula, you can take just a regular old shower, right? Like,
Yeah.
and that goes really far, right? Like, hey, I can give you back this little piece of your morning routine that you aren't able to participate in right now, right? Because we have this catheter in place. So I think if you can find some of these little things, again, ultimately the decision is always theirs. And I think that that's really the key, is the decision is, where their comfort is. Kids have the right to assent to their therapy, and we have to be respectful of that. And I think if you kind of come to it as a place of, like, I'm not your peer, I'm not your parent, I'm your physician, right? And I'm your physician in particular. And so I'm trying to think of all the different things in your life that have been altered by this diagnosis and trying to think about, how do I minimize your risk and give you a little bit of benefit?
I love that. And, in this event, infection prevention, we always want to, highlight the safety
Yeah.
of
Yeah.
fistula over a catheter. And
Yeah.
I wonder if, your pediatric population, have they shared what they are most worried about with you?
Yeah.
And,
Yeah.
does that change over time? Because you see
Yeah.
over the whole spectrum.
Yeah, so I think the things that they're most worried about, again, the first thing is that surgical intervention, right? And then the risk of reintervention, right? That's always sort of there with fistulas. And then over time, the second thing that they kind of come to is sort of explaining how that fistula is accessed, right? So like the second thing is the needles, right? Like if I can get them past the physical manifestation of the fistula, and I've won sort of um that that sort of quest, then it's like, well, wait a minute, I have to have these needles in my arm and I'm sitting here. And so then we start to talk about like that's actually sometimes a little bit easier in some respects because I can talk to them about like, well, when you were a little kid and we were doing blood draws, how did we mitigate the pain and discomfort there? So we talk about like freezy spray and lidocaine and like um don't use a ton of buttonholes, but like, if it needs must kind of thing. Um and so, and then, and again, it's always backing up that like, and remember, like your risk of infection goes down. So this is, and you're able to do like things like swimming and things like that in the summer. That tends to help build the case for the fistula. Um,
Yeah, and yeah, you brought about needle distress and you talked about how things look. It could be the scar,
yeah,
it could be the bulge.
yeah, yeah,
Do any of them talk about their peer reactions or what others would
yeah.
think?
That's a hard one to get out of kids sometimes. Like, I think they are obviously seeing me as their doctor. I'm not their friend. I'm not their parent. I do sometimes like if we're in an okay spot in terms of communicating, like if we have a little extra time, I try to get into like, well, have you talked to any of your friends about what's going on? This has been a lot going on. And I try not to do it in a way that like they can smell when you're trying to like sort of figure something out, right? So they're like, wait a minute, are you trying to get me with another doctor? Like, do you think something is going on, right? Like, kids are very attuned to like what you're, especially kids who've been in a medical environment. They're like, wait a minute, are you trying to like get me in with like a therapist or something? And my patients, of course, know that I'm a big fan of like therapy and working through things because I think having chronic illness as a child is really, really, really hard. Um, but I usually try to say like, well, what kinds of things would you do in the summer? Like what kinds of like, have you talked to any of your friends about what's going on? If we have like kind of that down moment. And I think that's really challenging because you have to kind of make it conversational enough that they don't um, put up some of the guards that I think most kids with chronic illness have sort of built. Um, and so just sort of being like, this is kind of a lot going on. Like, tell me a little bit about what's going on in school and seeing if I can like find some workarounds and stuff like that. One of my favorite things to talk to with my patients is school, and they all kind of roll their eyes at me. But like, I find that like you give them that little bit of like, I'm interested in what you are doing right now outside of this unit, outside of this clinic, outside of this, whatever space we're in. So
I think that's important, right? You want to develop that rapport and relationship because you got to break through that guard, like you said,
yeah,
and
yeah,
and that is probably done by the person with the most continuity of care, which in your
yeah,
case would be the pediatric nephrologist. And
yeah,
yeah, that's where the whole longitudinal relationship helps, because without that, they may not share all their worries with you.
yeah.
Yeah.
I think
So,
I think that's the strength of being a pediatric nephrologist. Like when I think about why I chose what I chose, the career that I went into, and I think my advice is knowing that some of our older adolescents may end up in adult units under the care of adult nephrologists. Um, you're going to have to reach back a little bit, right? Like you're going to have to kind of think about the fact that you're talking to someone who has is in the phase of life where they're just barely figuring out who they are, right? They've just sort of started to crest that wave. Um, and they don't, immediately once they've sort of hit that, I'm starting to understand who I am and who I am as a person and what I want to be. And now I've been given this diagnosis, right? And so, it helps to like just pay attention to the little things around them, right? Like talking about the stuff that they have at their bedside. Like if you got to go on the internet and like do a little research as to what's popular with this kid, with kids these days, I think that can be really like find the in. Like you have to kind of start to find the in, and like I said, they're very good at sort of sensing when someone is disingenuous or isn't fully invested, right? So like my advice to my adult colleagues is like just understand that one, they have seen so many more doctors than the average kid has. So they've seen it all. um, and two, like just sort of remove it, like removing all the like reasons we would do this X, Y, and Z, right? Like let's just talk about like what's going through your head right now and like what you're worried about. Which I think generally is just a great way to approach patients for the most part. But I think these kids are so savvy, and I think they can do well in an adult space, but I think you're going to have to sort of step it back from we're worried about infection, we're worried about access in the future. Like they're here and now, and they want you to acknowledge that you're here and now with them.
Yeah, and since you talked about infection prevention, now we know fistulas are always preferred, and they're the safest option. So how do you go around convincing your patient that fistula placement would be a safest long-term access, even if they prefer a catheter?
Yeah, I think there are a couple of things that I always think about. One is like normal, like standardization of care, right? So in the pediatric realm, there's this thing called SCOPE, which is our QI collaborative to make dialysis safer. Primarily set up around making initially PD safer for kids because we had really high rates of peritonitis. And so a bunch of centers got together and formed this QI collaborative that's still going strong. I want to say it's probably like 50 plus centers at this point. But there's ways that we standardize the care of the catheters, and there's ways that we standardize the care of the fistulas. And, when we still look at all that data, even when we standardize all the care of the catheters, you still see infections, right? And so like, I sort of put it out as like, we're going to do our best, right? Like to keep you safe, right? But if you end up with an infection, that's an automatic hospitalization in a lot of ways, right? Like, because inevitably you're going to have a fever, you're going to probably feel pretty ill. All of us are fairly risk adverse, and we don't want kids who have bacteria in their blood, outside of a hospital setting where they can get treatment. So, and I often say, and then that means another procedure, right? So like if you get a line infection, then well, we're probably going to have to change that line out, right? So it's kind of putting your money up front, right? With a fistula, saying like, I'm going to do this, and it might take a little more work at the front end, but it gives me a little bit of payoff on the back end. And it's going to still be there post-transplant, but that's just going to be sort of my safety net in some respects.
Yeah, and I think I'm hearing you, like, tell them about the infection risks and maybe ask them what matters to you, avoiding needles, avoiding hospitalizations, avoiding infections, and, trying to get some buy-in from them, like willing to hear about the fistula.
Yeah.
And like I said, the scar discussion, like you talked about.
We talk about skincare. Like we're big fans of like skincare. I was like, look, I will get you to plastics. I will get you to derm. Like we will tee you up. And you're finding these ways in which you can communicate with this individual who is just in a different space in their life, right? And they haven't had the ability to become an adult yet, because they're just not there. And so again, and selling it from the standpoint of like, I know that if I do these things, like put a fistula in you, that you're not going to need a catheter replacement because you got an infection, right? Like I know this, right?
Yeah, I sometimes just tell them like, I hear you, and my job is to provide you with the safest option and support your choices.
Yeah.
In adults, we have peer mentors, like we always have this a patient advocate. I don't know how you deal with that in peds.
Yeah, it's really so I think part of the challenge with that is that our populations at any one center are always really small, right? So, and to find a person who's sort of age matched, sort of matched from like a personality standpoint, like it's really challenging. So like, I do tap sometimes my post-transplant patients to see if they're willing to talk to my current dialysis patients. Um, and sometimes we can make that work. I always say there's a lot, overall the population of pediatric end stage disease is like such a small fraction compared to the adult world, right? And so I'd say sometimes, like having looking at other resources like the National Kidney Foundation and sort of like, kind of controlled spaces online, right? Like I don't love all of social media, but sometimes it does work to our advantage, right? And so it's like, maybe you and your parent can kind of like look online and see if there's anyone out there who's like you, right? Kind of thing, to find that peer group. Because I think that's the huge challenge is, my patients range in age from like 0 to like, 18, 19, 20. And sometimes it's like, well, I have a 10-year-old, I have a 12-year-old, I have a 3-year-old, and I have a 20-year-old. And it's like, there's no one who really matches, and that's the challenge. And also where just, I think where like the community of pediatric nephrologists is really helpful sometimes, like phoning a friend being like, hey, I got a kid who's really struggling here. Like, any advice you can give anybody that you've seen that's had this sort of thing. And sometimes that's, even just reaching out to your colleagues and stuff like
I like that. And we use the KDOKI update to provide like an individualized patient-centered life plan.
that. Yeah.
And just to help frame autonomy for the adults.
Yeah.
And, I like how you also started off by saying, we give them hope. We tell them about transplant. We
Yes.
try to, say that scars are going to come with transplant too. And
Yeah. I think it's for now, right? Like, I think focusing on here's where we are right now, but here's where we're going to hopefully be in a year, right? And, I think one of the challenges with our patients is that, it's hard for them. 6 months is both an eternity and a very short time, right? So, and it's in reference also to how old they are, right? So, like, 6 months for my 3-year-old is a lot longer in terms of their lifespan compared to 6 months in my 15-year-old. And so, um, trying to, again, sort of focus on how do I keep this situation where I know you need a therapy. I know you have to be removed from your normal social environment thrice weekly. And how do I keep you in that environment and avoid hospitalizations, right? As much as I can, right?
so are there any practical strategies or tips, where we are balancing, mentoring and
Yeah.
photograms, like, and what actually helps in
Yeah. I think just being it is so challenging as physicians in this day of age. Like, I think there's so many demands on our time. But if you can make that, if you're an adult nephrologist taking care of adolescent patients and you're having these conversations, like this is the thing to try to block your schedule for, right? Like if you can get them to start to consider these things, like it's worth your time and effort to like have that extra 10, 15, 20 minutes at the bedside, even if it's not even talking about the fistula, right? Like some of the best information I've gotten out of my patients have been literally just talking about a whole lot of like normal life stuff, right? Like, what are you doing this weekend? Well, I want to go to the movies with my friend, but my mom is like a little iffy about that, like, okay, well, let's talk about that. Like, how can we do that? I think getting them to understand that like you're not just another adult who is here to tell them exactly what to do, because they've already had to acquiesce a lot of the reins on their life, right? And you mentioned like a life plan, like they didn't even get to that step, right? And that is the hardest part about all this, right? I think where you can also build other bridges, like it doesn't have to be you, right? So like, if you're in a space where you're like, they're not buying it from me, like seeing if there's somebody else on your team who can like get a better in, right? Like I use my social worker heavily on the end stage or on the transplant side of things because sometimes they have just a little bit better like chit chat that, the kids buy into. But I think that my one piece of advice is it's actually worth the extra 10 minutes because they've been already shuffled around a lot in their life. And so like you sitting there and just sort of being like, okay, well, we're just going to chat about whatever it is that's bothering you. And you'll start to get the little pieces. They'll come out, right? Like it'll all filter out because they want to talk to someone about it, right?
Mm-hmm. Yeah, and so they probably share with you that it's the way I'm cannulated, or they probably want one
Yeah,
particular person that
yeah,
they trust to cannulate, and
yeah, yeah.
or
I
it could be timing, like you said,
Yeah,
like they don't want to
it's a
have the social
yeah.
stress of missing school.
And I think sometimes like it's a lot for them to admit, like, I don't want more needles because I have those I have them for so many other things. I'm like, fair enough, it's a bigger thing. Um, I don't want to look any more different than I already do, right? Like, and sometimes I think like acknowledging that like you've had the conversation, you've given the guidance and stepping back is totally reasonable. Like I think I've had a lot of success with being like, we're going to table it. We're going to table it. And like, you're going to think about it. And then I'm going to bring it, I'll say to them like, well, I'll be back on dialysis in April and we'll talk about it then. Right. Like I'm going to, like I'm not going to like harp on it. Right. Cause that's like, if you bring it up and up and up and up again, thinking about like what is their everyday life, well, somebody is probably telling them take their meds, watch their fluids, no, you can't have that snack, right? Like there's always somebody telling them exactly what to do with their body. And so like I'm going to say we'll put a pin in it and write things down as they come to your mind, right?
And have you ever looked into like a photo library? We've used that
Yeah,
sometimes. I know this is probably not data driven, but
yeah,
like showing them healed fistula
yeah,
or different skin types or body
yeah, exactly.
types.
Yeah, I think that's a real challenge because again, most fistulas end up in bodies that are a little bit different than theirs, right? Like the body of a 50 or 60-year-old is different than the body of a 16-year-old, and the skin looks different, right? And so I think that's where, like I said, in my very particular practice, we dialyze within the confines of an adult unit. And so they have actually seen a lot of it on a lot of different body types, but not a lot on their particular peer groups, right? And we have conversations about that. I was like, your skin is different when you're younger. Your healing is different when you're younger. If you're going to do this, actually now is a good moment to do it because your healing is going to be a little bit better. And like, you know, as I'm talking to my vascular surgeons within our system, I kind of say like, hey, they're like very self-conscious. Like, as you're closing, like be extra super duper conscious of those things. Please no staples.
Yeah, and you kind of have alluded to this, like we should know when to give
Yeah,
them space. And
yeah,
so, at what language should our listeners
yeah.
avoid, or
Oh,
what should be resonated instead?
oh yeah. Well, the kiss of death in any conversation with any adolescent, and I again reflecting on my life, uh, you can use your own personal experience. Like what's the thing that would always cause you to shut down? You have to do this, right? You have to do this, right? No, that's like you know big no 100% of the way. I think other things is um minimizing how it's going to be after transplant, right? Because it's still going to be there, and like being very honest with that component of it, right? Because sometimes they'll ask like, can we just undo it? And it's like, no, this is kind of a permanent thing. So like real honesty in terms of like what the actual plan would be for that fistula. um and then other things like anything that sort of feels like, well, we're just going to make the appointment for you kind of thing with the vascular surgeons. Like, I think, uh, again, they don't have control over a lot of different things, but giving them a little bit of control, like, hey, I know it's like another doctor's appointment, but like, it would be so great if we could just get you in for one appointment and you don't have to take it any further than that, right? Like, making it sort of low stakes to start, or even just the ultrasounds, the screening ultrasounds. Like, can we just do the ultrasound so we have it in our back pockets when the time comes when you think you might want to think about this? And again, respecting no, right? Respecting no, right? Because sometimes that's what you're going to get. And I think then, obviously, I'm always, as a person who's really invested in transplant, like pushing towards transplant as safely as I can get them there, because the reality is like, sometimes you can actually get to that point, if they happen to have a living donor or something like that. So those are the biggest things that I find the key when talking with them.
Yeah, no. Yeah, it's like asking them about the hardest part for them and saying,
Yeah.
tackle it together and being a team player with them, and validation is good.
We talk about like using my chart. I give them like, our phone number. I'm like, if you ever like kind of want to talk to me about this, like, you can. And I've had some kids take me up on that, which is, I think, kind of funny, because I think sometimes it's interesting because a lot of times these conversations are happening at the bedside or chair side, and families in there. And like, I think sometimes they do just kind of want to just talk to you about this, about mom or dad or whomever around.
Yeah, and I like it because you're approaching it as a team. Like, probably not going to feel easy, but we promise you're not going to be alone. We're going to be with you.
Yeah. Like, I'm still your doctor at the end of the day. And I think that, again, if I have any like selling point for pediatric nephrology, it's that they're always going to be mine until they actually sort of become full-fledged adults, right? So like, in terms of like my patients and stuff, I was like, the greatest success I can have is for you to not be my patient anymore, because I know you've kind of grown up and you're in a space where you can successfully transition. But it's a conversation for another day.
Well, thank you, Jill, for spending so much time with us. If you had to end on one or two points as takeaways or practical takeaways for our audience, what would you want us to take away from this podcast?
I mean, I think tapping into your experience in childhood, I think, is tremendously important when you're talking to these kids. They're obviously growing up in an era that is so much different than a lot of us grew up in a world that's very changing very quickly, and they can experience it all at the same time, right? So like, but some things are universal, that trying to find your sense of self, your peers, how you feel about your body and inside your body, like, these are universal things that aren't different from patient to patient, like in terms of like the fact that they're experiencing them. And then I think the other thing is like really helping empower them to feel like they're in a little bit of control. Because again, you kind of give them the options of access, but they can't choose to not be on dialysis, obviously, but they can actually choose their access options, and sort of helping them get to the point where they sort of make that decision that is sort of the best for them and safest for them. And, my hope is that they do choose something that has a lower infectious risk, but like, if they're not in that space, then I can't push it beyond that, and sort of recognizing the autonomy that they do have, right? So in that sort of era that they're in.
I love it. Well, thank you, Jill, for sharing all this with us. And like Dr. Rossi has said, that we want to understand their peers, give them autonomy, clearly explain the risks to promote fistula and avoid catheters, developing a support plan or control plan in order to deal with your pediatric nephrology patients. So thank you for taking time, and hope we chat again.
My pleasure. Thank you so much.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or another qualified healthcare professional. If you have any questions about any medical conditions or before or taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast by the American Society of Nephrology.